This first lecture is about normal labor, but not in the elementary sense. Normal labor is not the easy material that comes before dystocia. It is the measurement system by which dystocia becomes knowable. If that measurement system is crude, the diagnosis of failure becomes crude. If the diagnosis is crude, the treatment may still be technically correct in the operating room, but intellectually wrong before the incision was ever made. So we will begin slowly, because normal labor deserves to be studied with the same seriousness we give to hemorrhage, fetal compromise, or preeclampsia. It is a physiologic process, a mechanical negotiation, a statistical problem, and a clinical judgment under uncertainty. A good obstetrician has to hold all four at once. Let us begin, before the cervix is ever measured.
Human labor does not begin because one simple switch is thrown. Gabby describes the initiation of labor as endocrine, paracrine, and autocrine signaling among fetus, placenta, membranes, uterus, cervix, and mother. The exact human trigger is not fully known, and that uncertainty is important. In some mammals, labor follows a clearer fetal adrenal cortisol pathway with a fall in progesterone effect. Humans are different. Maternal and fetal progesterone levels do not simply fall near term in a way that explains the onset of labor. The better model is preparation and activation. Placental corticotropin-releasing hormone, fetal adrenal precursors, conversion to estrogens, prostaglandin pathways, oxytocin receptor expression, and increasing gap junctions between myometrial cells. This is already clinically meaningful. A contraction is not just a contraction. A uterus at term becomes more capable of coordinated work because myometrial cells communicate through gap junctions, because oxytocin receptors increase dramatically, because prostaglandin and calcium pathways become more active, and because the lower uterine segment, cervix, membranes, and decidua are participating in the same biologic preparation. The uterus is not merely squeezing. It is becoming an organ capable of coordinated electrical and mechanical behavior. This is why the latent phase is not empty time.
Friedman called the early part of labor the preparatory division. Gabby's abnormal labor chapter preserves the beauty of that idea. During latent labor, there may be little cervical dilation, but important connective tissue changes are occurring in the cervix. The word latent can make the process sound quiet or inactive. It is not inactive. It is less visible to the centimeter scale. That distinction matters because the centimeter is a seductive measurement. It is concrete, it is easy to write, it gives the team a number to compare. But the cervix is not only a diameter. It is a tissue undergoing effacement, softening, shortening, alignment, and dilation under the influence of uterine force and fetal mechanics. A cervix that is changed from thick, posterior, and firm to thin, anterior, and soft has changed profoundly, even if the dilation number has not satisfied the room. Now define labor with that caution in mind. Labor requires regular, effective uterine contractions that lead to cervical dilation, effacement, or both. The first stage extends from the onset of labor to complete cervical dilation. The second stage extends from complete dilation to delivery of the infant. The third stage extends from delivery of the infant to delivery of the placenta. But notice the epistemologic problem hidden inside this tidy definition. Labor onset is often known retrospectively. The patient may begin at home. Pain may precede measurable cervical change. Admission may occur after hours of contractions, or before the biology has declared itself. If we treat hospital admission as the beginning of labor, we may misread a physiologic process by anchoring it to an administrative event. Now we can understand why the history of labor curves matters. Friedman's work was extraordinary. In the 1950s, he transformed labor from a series of bedside impressions into a graphical object. He plotted cervical dilation against time, described a sigmoid curve, and separated the first stage into latent and active phases. In that world, active labor was expected around 3 to 4 centimeters. The 95th percentile rate of active dilation was taught as about 1.2 centimeters per hour in nulliparous and 1.5 centimeters per hour in multiparous. Those numbers shaped obstetric thinking for decades. The error is not that Friedman was foolish. The error is to forget what kind of evidence a labor curve is. A labor curve is not anatomy. It is not a law of nature. It is a statistical description of a population, measured in a particular era, under particular obstetric practices, and then translated into expectations for individuals. Once practices change, populations change, epidural use changes, oxytocin use changes, body mass index changes, maternal age changes, and cesarean thresholds change, the curve cannot be treated as eternal. Zhang and the Consortium on Safe Labor forced that correction. ACOG summarizes the shift clearly. The Consortium on Safe Labor analyzed more than 62,000 term, singleton, vertex vaginal births with normal perinatal outcomes across 19 hospitals. In those data, the latent phase had wide variation. From 4 to 6 centimeters, labor could be much slower than older expectations allowed. From 4 to 5 centimeters, labor may take more than 6 hours. From 5 to 6 centimeters, labor may take more than 3 hours. Before 6 centimeters, nulliparous and multiparous may dilate at similar rates. After 6 centimeters, multiparous begin to separate and move faster. Gabby gives the same lesson in another way. In a modern labor graph, 4 centimeters is not a reliable declaration of active labor. In one analysis, only about half of patients at 4 centimeters were in active labor. By 5 centimeters, about 75% were. By 6 centimeters, about 89% were. That is the intellectual basis for the 6 centimeter threshold. 6 centimeters is not mystical. It is a clinical compromise that protects patients from being judged by an active phase standard before enough of them are truly in active labor. This is why ACOG recommends that 6 centimeters be considered the start of active labor for management purposes, and why active phase management and active phase arrest standards should not be applied before at least 6 centimeters. Now, let that number settle into physiology.
Before 6 centimeters, painful contractions can be real, maternal exhaustion can be real, and concern can be real. But if the cervix is still in a phase where change is slower, more variable, and partly preparatory, then absence of rapid dilation does not carry the same meaning. At 5 centimeters, a clinician may need to treat pain, support rest, reassess fetal status, consider amniotomy or oxytocin in the appropriate setting, and make sure the induction process is adequate if the labor is induced. But the clinician should not diagnose active phase arrest. The phase has not earned that diagnosis. There was also no evidence-based diagnosis of latent phase arrest. This statement is not a minor guideline footnote. It is an act of diagnostic humility. ACOG states that no evidence-based definition exists for latent phase arrest, and that cesarean delivery for prolonged latent phase should be avoided when maternal and fetal status are reassuring. Gabe similarly emphasizes that the latent phase is highly variable. Many patients ultimately enter active labor, some stop contracting, and some enter active labor after amniotomy, oxytocin, or both. In selected exhausted patients, therapeutic rest may be appropriate. These are management pathways, not proof that latent labor has failed. The terminology matters because terminology becomes action. If a patient at 5 centimeters is called arrested, the room begins to behave as though a definitive pathologic state has been proven. If she is described instead as being in prolonged latent labor, or slow preactive labor, or induced labor, not yet active, the same facts remain available, but the inference is different. Good obstetrics often depends on preserving the right degree of uncertainty. Now we have to widen the lens beyond dilation. Gabby's normal labor chapter is explicit that labor progress is measured with multiple variables. With each vaginal examination, the clinician assesses not only dilation, but effacement, station, and position. That is not a decorative list.
Each variable answers a different question. Dilation asks how open the cervix is. Effacement asks whether the cervix is being taken up into the lower uterine segment. Station asks how far the presenting bony part has descended relative to the ischial spines. Position asks how the presenting part is oriented within the maternal pelvis. Contraction assessment asks whether uterine activity is capable of doing work. Fetal status asks whether time remains physiologically tolerable. These variables do not compete with each other. They complete each other. This is where the mechanics become elegant.
Labor is not a piston pushing a sphere through a ring. Gabb's phrase is powers, passenger, and passage, but the mnemonic should not be allowed to become simplistic. The powers are the uterine contractions, and later the maternal expulsive efforts. The passenger is not merely fetal size. It includes lie, presentation, attitude, position, station, degree of flexion, and fetal reserve. The passage is not merely a bony diameter. It includes the pelvic inlet, mid-pelvis, outlet, soft tissues, and pelvic floor musculature. The fetal head is not a rigid ball. It presents different diameters depending on flexion and extension. With good flexion, the suboccipitobregmatic diameter is presented, about 9.5 centimeters. As the head deflexes, larger diameters approach the pelvis. A head that is occiput posterior or transverse is not the same mechanical object as a well-flexed occiput anterior head at the same station. Position is therefore not an accessory fact. It is part of the diagnosis. Most commonly, the head enters the pelvis in a transverse position and rotates toward an occiput anterior position. Internal rotation is not an ornamental movement at the end of labor. It is the way an asymmetric fetal head negotiates an asymmetric maternal pelvis. Flexion occurs because of the shape of the bony pelvis and the resistance of the pelvic floor. Descent is not continuous. It is often greatest in late active labor and in the second stage. Engagement at 0 station tells us that the widest diameter of the presenting part has passed the pelvic inlet, but it does not alone prove that the mid-pelvis and outlet will be negotiated. Now, appreciate what this means at the bedside. 2 patients can both be 8 centimeters. In one, the cervix is almost completely effaced. The head has descended, the occiput is rotating anteriorly, contractions are strong, and the tracing is reassuring. In the other, the cervix is swollen. The head remains high, the position is persistent occiput posterior with deflection and increasing caput. Contractions are uncertain, and the tracing is becoming less tolerant. The dilation number is the same. The labor is not the same. This is why Spong's paper matters for more than the cesarean rate. Spong's Prevention of the First Cesarean Workshop insists that progress in the first stage should not be based solely on cervical dilation. Effacement and fetal station matter. It also insists that progress in the second stage includes not only descent, but rotation of the fetal head as it traverses the pelvis. This is not a request for vague patience. It is a demand for better observation. The same paper places this diagnostic discipline in the context of the first cesarean. It notes that cesarean delivery is common, that primary cesarean creates consequences for future pregnancies, and that institutions should attend to cesareans performed for failed induction or labor arrest without accepted criteria. This is not anti-cesarean rhetoric. A cesarean performed for a true indication may be exactly right. The problem is the transformation of incomplete measurement into a permanent uterine scar. Now we can define protraction and arrest with more respect. Protraction means slower progress than expected. Arrest means cessation of progress despite appropriate conditions and appropriate attempts at correction. The difference is not semantic. Protraction invites analysis. Which part of the system is slow? Is it uterine power, cervical readiness, fetal position, maternal effort, pelvic resistance, fetal size, maternal or fetal tolerance? Arrest is a stronger claim. It says that the system has stopped progressing under conditions where progress should be expected.
For active phase arrest, ACOG's current definition requires at least 6 centimeters, ruptured membranes, and no cervical dilation despite 4 hours of adequate uterine activity or 6 hours of inadequate uterine activity with oxytocin augmentation. Gabe gives the same operational structure. The 6 centimeter requirement protects the phase diagnosis. Rupture of membranes makes the labor trial more complete. The 4-hour and 6-hour thresholds protect against a premature inference from too short an observation. But notice the evidence quality. ACOG's 6 centimeter active phase recommendation is strong with moderate quality evidence. The active phase arrest definition is conditional and based on low quality evidence. The 200 Montevideo unit threshold is historical and mainly observational. ACOG notes that it comes largely from older data, in which most spontaneous vaginal deliveries with induction or augmentation achieved more than 200 Montevideo units. This does not make the number useless. It makes it a disciplined approximation rather than an absolute physiologic law. That distinction is the kind of maturity residents need.
External tokodynamometry tells us frequency and timing. It does not reliably quantify contraction strength or resting tone. Gabby explains that the external monitor records a relative change in abdominal wall shape. If the question is whether uterine activity is adequate in a protracted or arrested active phase after amniotomy, an intrauterine pressure catheter can measure pressure more directly. Gabby describes adequate labor patterns as contractions every 2 to 3 minutes, lasting 60 to 90 seconds, with peak intrauterine pressures around 50 to 60 millimeters of mercury, resting tone around 10 to 15, and total uterine activity roughly 150 to 350 Montevideo units. The commonly used 200 Montevideo unit benchmark sits inside this broader physiologic picture. The clinical point is not to worship the catheter. The point is to avoid diagnosing failure without knowing whether the powers were adequate. If contractions are inadequate, absent dilation may mean inadequate uterine activity, not true arrest. If contractions are adequate and the cervix still does not change after the required time, the inference of arrest becomes stronger. If contractions are frequent but low amplitude and painful in early labor, Gabby's discussion of hypertonic dysfunction reminds us that pain and frequency alone do not prove effective work. The uterus may be active without being efficient. Now, consider the passenger. Occiput posterior position is a beautiful example because it refuses simplistic reasoning. Gabby notes that persistent occiput posterior position prolongs labor and lowers vaginal delivery rates compared with occiput anterior position. But most fetuses in occiput posterior position undergo spontaneous anterior rotation during labor, so expectant management is often appropriate when conditions are safe. This is precisely the kind of fact that should make a clinician more thoughtful, not more passive. If a head is malpositioned, the diagnosis is not automatically cephalopelvic disproportion. Gabby is very clear that CPD is a diagnosis of exclusion, and that malposition is more commonly the culprit than true CPD. There is no reliable way to predict CPD before labor in low-risk pregnancies. Thousands of unnecessary C-sections would be needed to prevent one true case by crude prediction. Labor itself is the clinical trial of fit, but a trial of labor only teaches us if we observe it well. That means evaluating uterine activity, fetal presentation, position, station, estimated fetal weight, clinical pelvimetry, capit, molding, maternal effort, and fetal tolerance. It also means knowing when continued observation is no longer serving the patient. Now, move to the second stage. The second stage begins at complete cervical dilation. But the second stage is not only a clock. It is the phase in which the pelvic problem becomes dominant. Descent, flexion, rotation, extension, restitution, and expulsion. Gabby reminds us that although some descent begins before complete dilation, most fetal descent occurs after full dilation, when maternal expulsive effort can begin. ACOG defines prolonged second stage as more than 3 hours of pushing in nulliparous patients and more than 2 hours in multiparous patients, with individualized diagnosis.
ACOG also states that second-stage arrest can be identified earlier when there is lack of fetal rotation or descent despite adequate contractions, pushing efforts, and time. Gabby gives a complementary descent language. Protraction of descent is less than 1 centimeter per hour in nulliparous and less than 2 centimeters per hour in multiparous. Arrest or failure of descent is no progress in descent. Both require evaluation of uterine activity, maternal expulsive effort, fetal heart rate status, fetal position, and clinical pelvimetry.
The Israeli second-stage position paper adds an operational bedside layer. At full dilation, station should be assessed. Station is determined by maximal descent during contractions and pushing. Examinations every 1 to 2 hours should include fetal monitor description, station, and position. If insufficient contractions are causing arrest of descent, oxytocin is recommended. If malposition or asynclitism is the issue, manual rotation can be considered. Arrest is defined as no change in head station after at least 3 hours of pushing in nulliparous or at least 2 hours in multiparous. Prolongation thresholds are 3 hours without epidural or 4 hours with epidural in nulliparous, and 2 hours without epidural or 3 hours with epidural in multiparous. Senior assessment is needed when prolongation or arrest appears. And importantly, not every prolongation mandates immediate delivery. Now listen to the tension in the evidence. Longer second stage is associated with maternal morbidity, infection, hemorrhage, operative delivery, severe perineal laceration. ACOG discusses neonatal risk signals too, but in some cohorts, absolute neonatal risk differences are small, and the neonatal evidence is mixed. Even after more than 4 hours of pushing, one large observational analysis found that many nulliparous still delivered vaginally. But as time increases, the probability of vaginal delivery generally falls and maternal risk rises.
Therefore, the mature clinical question is not how long has she been complete. It is there descent? Is there rotation? Is the station low enough and the position known enough to make operative vaginal delivery possible if needed? Are contractions adequate? Is pushing effective? Is fetal status reassuring? Is maternal morbidity accumulating? Is the operator capable of the available interventions? Does continued time still have a plausible physiologic pathway to vaginal birth? That is what the clock is for. It calls attention to the need for a better examination. It does not substitute for the examination. Now return to the first cesarean. Spong's paper asks institutions to track cesareans performed for labor arrest or failed induction without accepted criteria. That proposal is intellectually powerful because it treats the diagnosis itself as a quality object. The question is not only whether the operation was technically safe, the question is whether the indication was earned. If a chart says active phase arrest, it should contain the phase, membrane status, contraction adequacy, and duration. If a chart says second stage arrest, it should contain time, pushing, station, position, descent, rotation, contractions, fetal status, maternal status, and the reasoning about operative options. If the chart says non-reassuring fetal status, it should specify the fetal heart rate category and the assessment that made delivery necessary. This is how normal labor becomes more than background knowledge. It becomes the grammar of honest obstetric diagnoses.
Let us now reconstruct the thresholds one final time as clinical reasoning. 6 centimeters is retained because modern data sets showed that many patients between 4 and 6 centimeters are not yet in the active phase by contemporary behavior. Before 6 centimeters, active phase arrest should not be diagnosed. There is no evidence-based latent phase arrest diagnosis because latent labor is highly variable. Onset is often retrospectively known, and most patients ultimately enter active labor, stop contracting, or can be helped into active labor when appropriate. From 4 to 5 centimeters, normal labor may take more than 6 hours. From 5 to 6 centimeters, it may take more than 3 hours. These numbers protect residents from importing Friedman's earlier expectations into contemporary labor.
Active phase arrest requires at least 6 centimeters, ruptured membranes, and no cervical change after 4 hours of adequate contractions or 6 hours of inadequate contractions with oxytocin. The 200 Montevideo unit threshold is a historical approximation of adequate uterine activity, useful when interpreted with the whole clinical picture.
For the second stage, ACOG defines prolongation as more than 3 hours of pushing in nulliparous and more than 2 hours in multiparous, but diagnosis must incorporate progress and clinical factors. Gabe and Spong preserve the epidural-aware 3 to 4 hour nulliparous and 2 to 3 hour multiparous reassessment ranges. The Israeli position paper operationalizes this with station, position, fetal monitor documentation, senior assessment, and no station change arrest thresholds. Final synthesis. Normal labor is not a reassurance phrase. It is a sophisticated model of biologic preparation, uterine force, cervical remodeling, fetal geometry, pelvic architecture, statistical expectation, and maternal fetal tolerance. The art is not to wait blindly. The art is to know what process you are observing, what evidence would show progress, what evidence would show failure, and what risks are accumulating while you observe. A clinician who understands normal labor can diagnose abnormal labor with humility and force. Humility because the system is variable and the evidence has limits. Force because when true failure is present, the indication becomes clear. That is the standard for this course. We are not trying to memorize cesarean thresholds as isolated rules. We are learning to see labor accurately enough that when we say failure, the word has been earned.